Hello and welcome, everybody. Our guest tonight is Albert Garcia-Romeu. Albert Garcia-Romeu, PhD, is an associate professor of psychiatry and behavioral sciences at the Johns Hopkins University School of Medicine. His research examines the effects of psychedelics in humans with a focus on psilocybin as an aid in the treatment of addiction. He earned his doctorate in psychology in 2012 from Sophia University in Palo Alto, California, where he studied self-transcendence, spiritual experiences, and their relationship to mental health. He completed a postdoctoral fellowship in behavioral pharmacology at the Johns Hopkins School of Medicine, where he trained in the conduct of clinical research with psychedelics and subsequently joined the faculty. Dr. Garcia-Romeu has authored numerous peer-reviewed articles, book chapters, and commentaries on psychopharmacology and mental health, and he has been interviewed widely in popular media. He is a founding member and associate director of the Johns Hopkins Center for Psychedelic and Consciousness Research. Welcome. Thank you once more for being here. I would like to start off with a very basic question. How did you start your work in psychedelic research?
Let's see. And I just want to say hi to Eric and Alan who are on here. I see who I met in Prague and when we were, our last trip out there to Europe, which was real fun.
Hi.
Um,
Hi, Albert. How are you?
hey, yeah, thanks for hopping on. Let's see. I was not planning on working on psychedelics specifically. I was mostly interested on the intersection of spiritual experiences and Western psychology, because as I studied more neuroscience and regular sort of standard Western psychology, I realized that there was very little framework for altered states of consciousness. They didn't really talk a lot about things like spiritual or contemplative or mystical types of experiences, or what they meant, or what their ramifications were. But there was a little bit of an offshoot of transpersonal psychology, which focused on that area. And so I found this graduate school, which is in Palo Alto, California, which is a very interesting place. It's near San Francisco. It's sort of what's called Silicon Valley. So a lot of these big tech companies actually are either housed there or started there, including like Apple and Google and Facebook or Meta. So anyways, I ended up going out there for a program, mostly to study spirituality and psychology, and the combination of those two things. And what I ended up studying was when people were having these, what we called self-transcendent experiences, what they meant to the people who had them, what the effects were on their mental health, which could sometimes be quite good and helpful. But other people actually had some pretty difficult times when they had these experiences, including ended up being hospitalized for, psychosis or mania. So it was a mixed bag. You would think this is all positive, but it's not. So that was very interesting. And that was kind of the beginning of how I got involved with this work, because when I was studying those types of experiences and their mental health outcomes, I went to go speak at a conference in Arizona towards the science of consciousness, which they do every year, and they'll move it around. So they do them internationally as well as in the US. But at that meeting, I went and had a small talk back in 2012 to describe some of my dissertation research. And one of the people in the audience happened to be from the Johns Hopkins group, and she was working on psilocybin research with Roland Griffiths. So she invited me to come back to visit the lab, which I did probably about a month later. I flew into Baltimore, and they ended up offering me a position there. And so it was not my intention, but the timing worked out quite well. And at that time, Matt Johnson and Roland Griffiths were working on their kind of building their program. There were just a few people working with psilocybin in the US. They had published 2 small studies in healthy people with psilocybin, and they were already working on studies for people with depression, with cancer-related distress, and also this smoking-related research Matt Johnson had started, but everyone was very busy and nobody had a lot of time to take these projects through to fruition. And so that was my entree into the field, because when I met these guys in Baltimore, they thought that my work was interesting and related well to what they were doing with psilocybin. And so then for the next several years, I started working with that team, and a lot of what we were doing was very applied, meaning we were giving people psilocybin high dose. We were applying various types of therapies like CBT or motivational interviewing, and then we were measuring the results. And that was the beginning of how I got involved with all of this.
I see. Thank you. So what I want to go with now is safety and some questions regarding that matter. So one of the questions that comes up relatively often, even outside of the clinical context, is how safe is it to mix psychedelics with prescribed medication, for example, trazodone or fluoxetine? And I'm also curious, what are the guidelines regarding that during clinical trials with psychedelics?
That's a great question. I should say we don't really know the answer. A lot of the data that we have are based on online surveys that we might do. Like my colleague Sandeep Nayak and Natalie Gukasian did a really nice paper where they got a bunch of people who talked about what their medicines were and their experiences using psilocybin or other classic psychedelics. And for instance, one of their main findings there was that for people who were taking, I believe it was lithium, that they were at great risk for seizures and bad effects when they were taking classic psychedelics in combination with lithium. And so that is one of the types of findings that we've seen with people who have been kind of concurrently taking these medications as well as using psychedelics. But it really depends on the medicine. I mean, obviously, a lot of these medicines can operate in different neurotransmitter systems. They work different ways in the brain. And so, lithium, which we don't actually understand the mechanism, to be frank, is quite different from a lot of these other drugs, and particularly SSRIs like fluoxetine, escitalopram, those types of medicines. Now that there have been a handful of small studies where people who have been administered these drugs for a little short period of time will then take psilocybin, and what they found is there's really not much bad effects there. To the contrary, it seems rather safe. The main things that they've noted in these small studies have been that people have less negative drug effects, meaning less anxiety or less fearfulness. So overall, the data that we have available seem to show that at least for some SSRIs or maybe even some SNRI medicines, the co-administration with psilocybin at least is pretty safe, not problematic. Other drugs like lithium, that may lead to some problems, including serious side effects like seizures, at least from the data that we have available. And then other medicines, trazodone in particular, I mean, is an interesting one. It's what we would think of as sort of an atypical antidepressant. It is a 2A antagonist, which is pretty much the opposite of what psilocybin and many of these classic psychedelics do. And so as a result, it pretty much abolishes any psilocybin effects. If you take a psilocybin dose while you've been taking trazodone, even PRN, and we have administered this, to people. There's no safety concerns. They just don't have any psychedelic effects either. And I think it's because it has affected their receptor availability for that drug. So, it really just depends. There are certain medicines that it's probably not good to be mixing with psilocybin beyond lithium. I know monoamine oxidase inhibitors, MAOIs, like Parnate or Nardil are a couple. They could potentially lead to a risk of serotonin syndrome. But yeah, we honestly don't have a great amount of data. And the main drugs that in our clinical trials we tend to rule out are things that are serotonergic, and really antipsychotic medicines and MAOIs and stuff like that, as well as some that may be on the market that may have some other 2A activity. I'm drawing a blank right now, but there is a medicine out there that is used, I think it's an antiretroviral for HIV that has 2A activity as well. But so there are a couple of drugs that we ask people not to take, but in general, it seems like the very common antidepressants are probably pretty safe.
Mm-hmm. But it's still, as I understood correctly, it's still advised to not take them directly prior to the session, or how does it work?
We kind of have various responses on that front. Some it depends on the population and the study, but usually we'll let them take the drug every day leading up to a dosing session, and then on the dosing session day, they may either take it or not take it, and that kind of depends on what their doctor thinks and what the facilitator thinks. So we don't have a very hard set rule, but again, we don't seem to, we don't think there's a concern about mixing those two types of drugs generally.
I see. So my next question would be about the so-called bad trips. What is your take on this phenomenon? And are there any substances with which one might end such bad trip and interrupt the psychedelic experience?
So there's a lot of reasons people can have a, difficult experience with psychedelics. Sometimes they can just be overwhelmed by strong effects. Other times they can feel, really strong negative emotions like fear, anxiety, paranoia. And so that is a type of thing that is difficult for people to predict before they get into the experience. But when they are in there, there are medicines we can use to at least attenuate those types of reactions. And usually we would give them first something like a benzodiazepine or anxiolytic medicine, like Valium or something like that. That typically works most of the time. If we need something more powerful, then we're able to use antipsychotic medicines. And so that would be something like risperidone orally. And so that's always available during our drug sessions. But I would say in over 1,000 dosing sessions at Johns Hopkins, we've only used a medicine like that maybe 3 or 4 times. So it's less than 1% of the time that we have had to use it. So it's exceedingly rare. And I think that's a combination of factors for that, meaning that, our preparation and our screening helps to avoid those situations. And also just having the very safe container where we do all the dosing sessions under supervision seems to put people mentally at ease. So that's normally not something we have to do, but we're prepared to do it if it's needed.
I see. So this is a rare situation when you actually terminate the trip with some other medicine. What about the so-called serious adverse events in trials with psychedelics that participants and researchers should be aware of, in your opinion, to be prepared, like you say, for it?
Yeah, I mean, we have for our research, usually we have a very specific definition of serious adverse events. And so that would include anything that leads to death, um, hospitalization, long-lasting congenital or other types of problems that might be caused. So those have been pretty rare in the literature. Certainly with psilocybin, we don't see a lot of that type of thing happening. Um, the closest thing I could think of has been suicidal ideation and behavior that was reported in the COMPASS trials. Now you have to realize this is a population with treatment-resistant depression, so they're already at high risk of experiencing suicidality. But nevertheless, it did seem to happen at a higher prevalence in the high dose group. And so it does create a potential concern that for some people, they may respond poorly to these medicines, or they may need a lot of monitoring to make sure that they don't develop suicidal ideation or anything like that. And we have a lot of safeguards in place now in our studies, which make it so that we do not necessarily, or so that we're constantly checking on suicidality, just so that we're not putting anybody at risk of those types of harms, or at least if they're developing those problems, that we're aware of it. Other psychedelics like ibogaine, we have seen more serious, cardiovascular related issues, including deaths. I think there's been maybe a dozen or so deaths reported in the literature internationally where people are receiving the drug. But that drug, ibogaine specifically, is a little bit more pharmacologically complex. It has some pretty intensive cardiovascular effects that can lead to things like prolonged QT interval or other types of changes to heart rate and blood pressure that can cause cardiac arrest. So that's one to be concerned about. In the more real world literature, there was recently a interesting case report published from a young man who had taken psilocybin, out there by himself, ended up taking a pencil, grabbing onto it, and then slamming his head into the desk, and then that went into his eyeball. Thankfully, his family was there. They were able to stop him. They called for emergency, support, and that was removed. But obviously, there's quite a lot of damage done, and so people can have these very intense, spontaneous, and negative reactions sometimes. And we don't see that as much, obviously, in our well-controlled studies, but out there in the world, I would imagine there are a slightly different profile of risks. And especially if we start to see more of these vicinities like Oregon or Denver, Colorado, where they're allowing administration of psilocybin or other psychedelics, we might see more of those pop up, unfortunately. And I think that's just a function of the monitoring that they're using, which in Oregon, you only have to have like very little education. You don't have to have any medical training to be facilitating. And so that could lead to problems, particularly in people with vulnerabilities, like who have a predisposition to some psychotic illness or something like that.
So when we're already talking about how psychedelics are used legally in the United States nowadays.
Sort of legally, I should say,
Okay.
because we have two levels of government, I suppose. One is the U.S. federal government, and at that level, these drugs remain illegal pretty much across the board. And then, there's also a level of state government, and there's 50 different states, so they all have their own laws. But in each of those states, there have been some of those places that have opened up provisions for access or decriminalization of psychedelics. And so in those places, at least the state authorities won't bother you if you're using psychedelics, probably.
Mm-hmm.
But it's possible that federal agents could come get you if they wanted. I don't know that it's happened quite that much, but it is possible.
Yeah, this is a situation that might be difficult to imagine in terms of legality. However, my question is this: if psychedelics were legal, how would you design a facility that would give people access to psychedelics so that it would be safe and professional?
Well, I don't think it's all that complicated. The problem is that it is, from an economic standpoint, going to be a little bit complicated because it will take a lot of, expertise and oversight to do safely. But I mean, really, and there are great examples in Switzerland where this is being done, already, where people can have a therapy office, they can have a medical doctor who's screening patients before they get the drug, and they can have somebody, qualified, be that a therapist, a nurse, or a physician, who is overseeing the session. And I think a lot of the parameters that are needed have been published, by Matt Johnson and Bill Richards and Roland Griffiths in 2008. They published a really nice paper about how to do this stuff safely. And, since 2012, I've, done a lot of work with psilocybin in the lab using that type of safety guidelines, which includes, a thorough medical and mental health screening that we do, a thorough support process, meaning that there's preparation happening with the individual before they get the drug, that they get a lot of briefing about what to expect and how to navigate difficult experiences. That can sometimes include things like training in mindfulness or deep breathing exercises or other types of techniques to deal with, very intense emotional states. And beyond that, just having those monitors, present during the session, and then having a structured integration process, meaning we don't just give the person the drug and send them back out into the world. We want to make sure that we're keeping in touch with them, that if they're having a difficult time, that we can help them mitigate that. If they're having, profound insights, that we can help them work with those to get some benefit. And even if we cannot directly ourselves be the ones who are providing all of the support, then we should already have a built-in infrastructure of referral system, so that if there's, we know that we're dealing with patients with trauma or with substance problems or other types of issues, that we can hand them off safely to somebody who can take care of them. And so that, I think, is the kind of minimum. Obviously, there does need to be, I think, some level of training here for the people that are doing the work. But, medical doctors, psychotherapists, nurses, those people have the training necessary, and they work with other types of medicines, on a fairly regular basis. So that's one of my only concerns, in places like Oregon, where, because of the economic pressures, which is someone with a PhD or an MD or a nurse might cost quite a lot of money to sit there for 8 hours. That makes it so that sometimes the people that are sitting there don't have a lot of training or education. And if the person comes in the morning and says, oh yeah, I just started my new medicine, lithium, this morning, I'm ready for my dosing session, they might not understand the pharmacology that would make this risky. Whereas a medical doctor or a nurse would say, well, wait a minute, we're going to stop right now and we're going to, reevaluate. So I think that's my, thoughts about how it can be done. I don't think it's that difficult, though, and these drugs are not that dangerous. The main thing is that as more people are trying to use them, particularly people with mental health related issues, and often those people are already heavily medicated, that just puts us in a territory where these people are at higher risk for, psychiatric events, as well as potentially difficult experiences and medication interactions. So we just have to be mindful about managing those safely.
Yes, that's very important what you say. I have a question about the costs, because you mentioned that highly qualified people may be costly to hire. Meanwhile, Alan, I see that you are raising your hand, but if you can wait, please, after the break, there will be a whole section of questions from the audience. Now I would like to continue with my set of questions. But about regarding the cost, I've read your editorial you co-authored called Innovations in Group-Based Psilocybin-Assisted Therapy of Major Depression in Patients with Cancer. And if I understood correctly, the authors, including you, suggest that possibly group therapy with psychedelics may be a solution to high costs of psychedelic therapy. How does it look like right now? What are the current achievements in that regard and the future perspectives?
Well, this is, I think, an area in science and medicine that's still developing, but there has been a history of practice in indigenous, traditions, as well as even in like retreat types of settings where people will go. Maybe many people will take ayahuasca. There may be 3 or 4 people there facilitating that process, but you may have a dozen or more people on the medicine at the same time. And I think that can be done safely. Um, but in terms of where we're at with the current medical model, that editorial we wrote in response to a nice paper that was done by a group near here in Maryland. And what they did was they took cancer patients. They basically instituted a sort of ongoing weekly support group with that cohort of patients, where there may be anywhere from like, I think, 3 to 4 patients at once. They would be going through a process of preparation in the group. They would also go through integration to talk about their experiences afterwards in the same group. And then they would have their dosing sessions when they could schedule it on the same day. Although at least in this particular study, they were each in a separate room. But you can imagine if it was like in my house, there's 4 bedrooms, and so in one room, one person is having an experience and so on. And so people are sort of spread out. And there are different facilitators keeping an eye on them. So it's not 100%, solving the cost effectiveness problem, but just because of the group preparation and the group integration, it does help with the labor and the amount of effort and time that is required. So I think those types of models will be increasingly important to study so that we can kind of have better economic viability of these models of treatment. And then, how do we do these types of drug experiences together safely? And, when I was in Prague recently, when I saw you, all of you guys, I ended up speaking a lot with Torsten Passi, who's done a lot of this type of work, including in groups. He's a really interesting fellow, very smart man. But he was saying that they can do group sessions with many people on the drugs in the same place pretty safely. So I think that's probably something else that we'll be seeing more of too, is just that people will try to find ways that they can do that. Hopefully that will allow people to still have a very meaningful introspective experience without necessarily needing to have one-on-one facilitator or monitoring, which I think is where the time and cost come in. So
Right. So that sounds pretty promising. Um, let's go into the stages of the clinical study with psychedelics. Maybe if you could elaborate a little bit more about preparation for those people who are not well informed already. How does this preparation look like now in studies that you are doing?
Well, it sort of varies because in some of these studies, for instance, if we're working with patient populations who have like a substance use disorder versus someone who has an eating disorder, uh, versus someone with existential distress and a terminal illness, there'll be some variations in obviously the content and the structure of the therapy. But the very kind of broad strokes, I think, are something that translates regardless of the population. And that there's a few main things that we do in preparation. One of them is just getting to know the person's life history. What were the main formative events that led them to where they are in their lives now? What were specifically any traumatic events that may have stuck out to them as particularly impactful? So we want to just get a sense for that, their life history and what have been some of the most important things that they've gone through, and as they see it. That includes things like their relationships with their parents, but also with their, romantic partners, friends and coworkers, talking about their professional lives, talking about their, worldview or religion. So really kind of having a very open-ended conversation, which this is something that we typically do over 6 to 8 hours over the course of 3 or 4 weeks, I would say. That is, I think a initial starting point. Another thing that we always do is psychoeducation, which is basically, here's what psilocybin is, here's how we think it works, here's what you should expect during your dosing session. If you're having a difficult experience, this is how we suggest you try to navigate that. So we give them a lot of information so that they feel prepared for the drug dosing. And then, that is all leading to sort of a rapport building anyways, by kind of spending that time together, we're building a therapeutic alliance, a working relationship where they feel that there's a sense of trust between, the people that are going to be facilitating and then themselves. And that's incredibly important, I think. And those are the main themes. We may get into building treatment goals when we're dealing with particular populations. Like if we have people with alcohol use problems, then we may drill down into some really specific content around what happens after the sessions, and what does success look like, and what does failure look like, and how do we deal with if we don't necessarily meet that bar that we're looking for. And so we definitely do a lot of discussion around what the therapeutic goals could look like for people, but that's tends to be very idiosyncratic, because for one person success may look very different from another person. But those are the types of conversations that I think are pretty fundamental to doing the preparation. And anything beyond that tends to be more on the lines of real, manualized or protocolized psychotherapies using motivational interviewing, or using cognitive behavioral therapy, or some other form of talk therapy or intervention to try to bolster or support like the whole process. And that, sometimes we do that and sometimes we don't. And I would say, depending on the population, we've seen success with or without it as well.
So you've discussed the preparation briefly. I will have some questions regarding that, but what about after the experience? What about the integration?
I would say the integration process also tends to be open-ended. A lot of these new companies that are trying to get medications approved using psilocybin or other psychedelics, they really want to truncate that process to make it, again, more cost effective. So they want to see someone maybe once or twice after a dosing session. Now, I'm, not necessarily thinking that you need to be in therapy for months and months afterwards, but I do think that for due diligence, it's important to have at least a follow-up period of about 4 weeks for a person to acclimate after a dosing session. Sometimes somebody will walk out of the session and say, that was no big deal, I'm fine. And a couple of weeks later, they may still be having some emotional or other types of existential concerns that have kind of arisen from their experience. And so although they might have discounted that initially, there might have been a lot going on still. And so it's easy to just let someone go after a week or a couple of days and not really keep good track of what's going on, where there potentially could be a lot going on still. And so normally in that process, we just kind of spend a good amount of time, usually once a week for at least 4 weeks, I would say, just checking in, where are you now? How are you feeling? What was your experience like? What, if anything meaningful arose out of that experience? If there were sort of any particular concrete insights or things that they took away from that, how are they incorporating them into their lives? And I think that tends to be one of the most important places that we as like facilitators or therapists can help get the most out of this. Because if you dive into an altered state of consciousness, you can be altered for 6 to 8 hours and come back and basically be just the same as you were without changing at all. Or if you're really seeking to create altered traits or long-term changes in the individual or their behavior, then that's going to take more effort most of the time. It's going to take some concerted work. And so that means we're going to be coming back to that and saying, well, what changes have you made since your session, and how are they supporting you, or how are they keeping you off track from your goals? And so in that case, it's I think very similar to a lot of standard psychotherapy, with the exception of, there tends to be, for some at least, a big focus on, the contents of their experience and or any sort of psychic material that might have come up during that. Because for some people, which has been really interesting to see, they may come in. I'm thinking of a very lovely older woman, in her mid to late 60s, who wanted to quit smoking. That was why she was in our study. That was, she experienced psilocybin. And during her session, there was a whole litany of childhood experiences that came up for her, including some around sexual abuse by close people to her. And, for those memories to come up, that was very unexpected. And it was also emotionally very intense. And it took some time for her to sort of work through that. Certainly not something that you just kind of talk about for a week or two and then, send someone on their way. And thankfully, we were able to work with her for a time afterwards, and then we were able to link her to additional, follow-up support. But, I think, again, this is really going to vary from person to person, because some people, may not necessarily have a huge aha moment or, insights from their experiences, and yet they may feel like their depression is lifted or their anxiety is improved significantly. And in those cases, we're just kind of there to provide a container and support, and then also to make sure that, generally speaking, they're not encountering any of these weird after effects, like HPPD or anything else that's lingering that's unusual for them.
Speaking of HPPD, could you explain briefly for those who are not familiar with the term what that is?
Yeah, I mean, it's a condition that we call hallucinogen persisting perception disorder. And for some people, and it's actually a woman just sent me an email yesterday about her daughter. And so the story was, that she's told me was that her daughter went to Oregon for depression, took psilocybin once, had a very good experience, went back for another round of treatment, had a very difficult experience where there was some significant panic and paranoia, and that after that had developed some both visual snow. So basically, these different kinds of floaters or changes in her visual perception that can include distortions or hallucinatory sort of perceptions in your periphery. And that also often comes along with a significant amount of distress. So it can be frightening, or it can cause heightened anxiety for people. And so that was what this young woman is experiencing now. And what we, is one of the presentations you may see for something like HPPD. We don't understand how it works, why it happens. It tends to happen more so in recreational contexts. So all these people that we work with in our studies very rarely report anything like HPPD. Sometimes you may see like some lasting changes in perception that aren't necessarily experienced as distressing in any way. So I'm thinking of a older woman that I had treated many years ago who said she was on the bus. She was looking at a man, he sneezed, and when he sneezed, his breath came out, and there was also the sun behind him, and there was also this, what it kind of looked like a rainbow kind of came out of, his breath and the vapor from his sneeze. And she said for a moment it reminded her of her session, but it was not something that was distressing or worrisome. And so we hear about that type of thing from time to time in our well prepared and screened participants. But I would say, for recreational users, they might report these HPPD symptoms, including, emotional distress, more often. And that seems to really come along with a certain certain types of people tend to develop it. Often people are already dealing with a high deal, a high, amount of anxiety, I think. And so this tends to be like another manifestation of that, or can be.
So what's your advice if someone is suffering from that after psychedelic experience, not in this light form, but in this hardcore form? Are there any guidelines for people?
So people have tried using various medicines to try to alleviate that, anything from benzodiazepines to different types of antidepressants. Some of them seem more effective than others, but we don't have a standard treatment. And so this is on a case-by-case basis. And so, for instance, with this young lady, I'm referring her to a psychiatrist who's going to work with her to try to figure out, what's appropriate. And, her symptoms are panic and panic disorder related symptoms, including, panic attacks, high anxiety, trouble sleeping, insomnia, and then also some of this visual snow phenomena. And so I think the doctors are probably going to work with her both to do some talk therapy around her anxiety and panic symptoms, but also using some pharmacotherapy, maybe some sort of anti-anxiety or antidepressant medicines that may help also alleviate some of those issues. But yeah, there isn't like a standard treatment as of yet.
Yeah, what you said sounds very reasonable. And also my thought about the importance of the preparation that you described was that it's absolutely vital, because then with preparation you might actually know whether possible adverse events would somehow correspond with the previous psychiatric conditions that psychedelics only exacerbate, or it's generated by psychedelics themselves. So it seems vital to have. How many sessions do you have for preparation?
You can do anywhere from two. I mean, some people do very minimal preparation. I like anywhere from 2 to 4
Mm-hmm.
sessions of preparation, and it depends. When you have a much more, severely, challenged population, if they have like very strong, trauma, for instance, or trauma history, you may need more time to prepare. These people may not feel safe after a couple of hours sitting with you. And so it depends. But yeah, I think on average, we're doing 3 or 4 sessions. Usually those are 90 minutes to 2 hours apiece. So we're talking about 6 to 8 hours of prep before a dosing session. And that seems pretty, I think, sufficient for most people we worked with.
I see. So what psychotherapeutic modality is most suitable for psychedelic assisted therapy, in your opinion?
We don't really have a good answer to that. There's actually been almost no research. So some guys at Yale, like Jordan Schlosshauer, and some of his colleagues have done like ACT, which is acceptance and commitment therapy, with psilocybin for depression. Other groups have used other types of treatment, including, we've used cognitive behavioral therapies for smokers. We've used motivational enhancement or motivational interviewing for alcohol use disorder. But nobody's done a nice big study to compare various types of therapies and to see what the difference is. And I suspect that, just like everybody on this call is going to like different type of music or different type of food, or different types of books that they like to read, that there's probably going to be a lot of individual variability in terms of what therapies are going to work for people. And so some people may just do better in certain types of therapies. Probably the best study that was done on this, which I like a lot, was done by Celia Morgan at Exeter. And so she was using ketamine to treat alcohol use disorder, but they split their patients, and I think there was 100 or maybe more than that patients altogether. But that's how many you need. You need 100 or 200 people or more to start looking at these types of effects, so it's quite complicated. But then she set them into 4 different groups of people. 2 of those groups got ketamine, 2 of those groups got no ketamine, and 2 of those groups got some specific therapy for their alcohol use disorder, and the other 2 got psychoeducation. And so in the most placebo group, you got basically a psychoeducation, like drinking is bad, you should stop, and no ketamine. And then there was sort of variations on that in 4 different conditions. And you could actually see the improvements, based on the intensity of the therapy and the use of ketamine or not, that across the 4 groups, there are differences in the improvements, but it's not a substantial difference. And a lot of that probably has to do with the variability that I'm talking about. Nevertheless, the people that got a sort of targeted psychotherapy for alcohol use disorder with the ketamine were the ones who tended to do the best. And so that intuitively makes sense, which is when you're using, a targeted therapy, and you're using medicine like ketamine, you're going to get the best outcomes, as opposed to obviously a placebo medicine. But I think these types of very low intensity brief therapies or psychoeducation, are not going to have the same type of impact. But it really depends. It depends on the individual and the condition.
Yeah, but it's an interesting study design,
It
and
is, yeah.
I think we should do more of that.
It's
But
expensive, so and it takes a long time. So
yeah, yeah. However, coming back to addictions, in a paper from last year that you co-authored called Impact of Psychedelics on Craving in Addiction, a Systematic Review, you stated that, quote, this must encourage further larger scale trials to be conducted to clarify the efficacy and to better explore the mechanism of action of psychedelic substances in the treatment of addiction, end of quote. So if I understood correctly, there's still not sufficient information about how psychedelic therapy affects craving. So what should be done in that particular regard, in your opinion?
well, we can do more big clinical trials, which I think will be done. Michael Bogenschutz did a very nice one. I'm actually reading right now one of his follow-up papers. I'm reviewing it for a journal, so it's pretty neat because we're looking at, in that paper, which will probably be published soon because it's quite well done, some of the mechanisms, including things like mystical experience. And, Matt Johnson and I will soon publish some more work on smoking cessation, and then that will both show the efficacy related data, did it work or not, which, it worked quite well for smokers, the psilocybin, but then more on the mechanisms. But actually, some of the types of studies that we can do that are quicker and a little bit easier, are more lab-based studies. And so we can just bring people in, for instance, maybe even people who don't want to quit smoking or people who don't want to quit drinking. And we can maybe put them in a place where they're abstinent for a few hours and maybe give them psilocybin or some other type of medicine like a placebo or something else. And then we can just measure their craving during that period of abstinence. And so if you have a smoker in a room who's accustomed to smoking 20 cigarettes a day and they have to sit in a room all day without smoking, their irritability is going to go up, their craving and their withdrawal symptoms will increase naturally over time. And so if you can give them a you know, and over the course of a day, dose of psilocybin, and then see what happens to those responses, or give them some other medicine like, you know, methylphenidate or something else as an active control and see what happens there. You may be able to start parsing out a little better some of these questions about craving. And actually, it's funny, I just came back from a meeting in New Orleans where I was with the author of that paper, Sophie Athena Chaperon, who's a addiction psychiatrist in Bordeaux. But yeah, she's quite lovely. And, you know, we were talking a lot about this stuff, you know, how do we study this better? Because we don't have good answers. And I think clinical trials are one way of doing it, but clinical trials tend to often focus on efficacy. And so some of these smaller lab studies can be a good shortcut for us to get more information about specific mechanisms like craving or withdrawal, or, you know, delay discounting, psychological or cognitive flexibility, those types of things, which seem to be appearing more and more as really important for people with various disorders, like, you know, both depression and substance related. So.
That's extremely interesting, and I would like to ask some questions specifically to this topic, but since I want to make a break and give space to others, just some final questions from me. First of all, was there anything that surprised you specifically during your career as a psychedelic researcher?
I've been surprised, and I guess I should not have been, but, you know, having not had a very traumatic upbringing, so I suppose not having a lot of uh, personal experience, you know, what has been really interesting to me has been seeing how people with a trauma history respond to these drugs. And for some, this can be really a positive experience, where they can re-experience their trauma, but also feel safe and kind of help reprocess it. And for other people, it's been almost the opposite, you know, very difficult for them to relive. And even when they don't want to do that, it often forces itself up to the surface. And so I suppose seeing that in person, working with someone who's coming in to deal with a completely different issue, like smoking, for instance, and then all of a sudden, you know, having these incredibly powerful memories about, you know, abuse or, you know, different types of trauma coming to the surface and really imposing themselves into the experience, has been very illuminating to me, in terms of how the mind works and how we have our psychological defenses in place and how these drugs can really change that dynamic in a way. So that has been, I think, really a learning experience for me. Um, I mean, the main thing I've learned a lot more of, you know, with my work is just the amount of humility and that we need to have when we do this work, because it is fully impossible to predict how anyone will respond to the drug. And you might give someone a dose that you think is trivial, like 15 milligrams of psilocybin, and they may have a very intense response that you have to really, you know, be closely monitoring. And other people may take a very high dose and they may, you know, talk a lot about their spirituality, and, you know, you might think that they're geared to have a spiritual or mystical type experience, and they may have, you know, nothing like that. And so really just having to go in and say, even though you're the expert, you know, that we don't know what's going to happen, and that is part of the process. So I guess learning to work in those circumstances has been, well, one of the neatest things that I have, you know, been able to encounter, but also it's, you know, can be quite challenging because, you know, obviously we want to be in control of the situation, when we're trying to administer an intervention, but there's only so much we can control. And certainly what's going on in the other person's psyche is something that we cannot really impact, you know, not profoundly anyway.
That's great. I think we might end this part right here. Thank you most kindly. And now let's take 5 minutes break. And after the break, we would welcome the questions from the audience. So let's take 5 and see you soon.
Great. Thanks. I'll see you in a minute.
So we're slowly coming back after the break. Now it's time for the questions from the audience. So I will just briefly explain the procedure of asking those questions. So if you come up with a question, please raise your hand in the way that Alan did just before in the previous part. Can you do this, Alan, to show us how to raise your hand exactly like this? So this is a sign for me that you have a question, and then I might give you the voice. So Alan, you have already had a question before, so now the floor is yours.
Thanks, Alex. By the way, if you don't know, the function is on the bottom, there's a button that says react, and you can just press it. Albert, yesterday we had a central session at Unimind with CJ Healy from the New School of Social Research, and there's a paper that you helped publish about naturalistic settings and group experiences with an improvement in certain symptoms of childhood maltreatment trauma in relation to PTSD as well. And we talked about the fact that they have seen quite surprisingly big effect sizes in improvement of symptoms, while there were also some people who fared a little bit worse. But these effects were actually quite comparable between ceremonies settings and raves, which is quite surprising for me to see because you would expect that a place like a rave where there's much more people, maybe much more place for things to go wrong or things that you maybe cannot control that well. So I guess my question is, we were also talking about before about scalability and cost effectiveness of therapies. So if you go to a clinic, you're expected to pay, at least for ketamine sessions at the moment, thousands of dollars, even after reimbursement by the insurance companies in the places where that's legal. Do you see something like this, settings like those, people taking psychedelics by themselves in the settings of being with their friends, family members, ceremonies, raves, and then attending perhaps integration sessions, and that would be a fraction of the cost of going through an entire session of many weeks, months preparation, personnel infrastructure. And my follow-up question, if you could comment on that as well, since integration seems central to this, and the experience seems central to this, and that's why maybe people need the integration because the experience can be difficult. What do you think about this new non-hallucinogenic psychedelic LSD, non-hallucinogenic LSD that came out of I think UC Davis? I don't remember, sure. By
Yeah,
David Olson.
yeah. First, yeah, the first part of your question, that was a really cool paper. So that's from CJ Healy, and that was their dissertation work, which was nice. And for people who are not familiar with the paper, we published it earlier this year, but CJ collected a bunch of data from people who either took psychedelics, and that's broadly construed, so including MDMA, psilocybin, LSD, either in a rave or like an electronic dance music type setting, or in a more ceremonial type setting. This would be something more like a retreat setting or a ritual of some sort, typically with a shaman or facilitator. And across both of these groups of people, which was a fairly sizable group, if I remember, it was probably about, I want to say about 80 people total. What we ended up seeing was that both the people in the rave settings and in the ceremonial settings were both showing significant improvements in their trauma history, in their self-image and self-concept. So, there's a lot of mental health improvements that they were reporting post hoc after their experiences. And that didn't differ between the two settings. So you might think, that a ceremony or something that's more intentional or a smaller group would have a better impact, but it didn't. And in both of those groups, we also saw that the subjective effects, specifically things like emotional breakthrough or what we call oceanic boundlessness, which is like a feeling of unity, basically, seem to mediate the benefits. So great paper. So I think there's, one of the things that we'll probably get in that type of research is a self-selection bias. So a lot of the people that are going to show up are going to talk about how great and how big their experiences were. And the people who probably didn't have that great of an experience might not have responded to this type of a thing. So that's a problem with this type of work. But it does show that there are people who are at least, perceiving themselves to have benefited really significantly from those experiences. Now, your actual question was, can people go have their experiences in these types of settings and then engage in post hoc, psychedelic integration or just therapy? And I think absolutely. And it actually has become a thing that people are doing, is that they're, engineering their own experiences at home or with a small group of friends. And then whatever material comes up for them, then they're going to work with a therapist, usually someone who has some integration or support, for psychedelic type of familiarity. And I think that's a very viable model for certain people, particularly for people who have already a pretty good, what you might consider ego integrity or ego function. And so if these people are not necessarily in crisis where they're at risk of like, feeling suicidal or potentially like at the brink of like a major breakup where they're going to leave their partner of many years or leave their job or, make a major life decision, or so those types of folks I think are probably fine to engage in that. Ideally they'll already have some experience with these psychedelics then, so that they're not just going in blind. And, of course, the other risk of doing something like that is that you may not know what drugs you're getting or what dose you're getting. And that is always, something that happens when you take illicitly sourced substances. But there are ways around that, drug testing and, stuff like that. But I do think, yes, it is a sort of viable model. And that is something that people are certainly doing, which is going to have their own experiences and then bringing that content to a therapist, so that they don't have to necessarily pay for the whole package, which can be, as you said, quite expensive.
And
And then
before maybe you go on to the second question, I'll ask a little follow-up. If you wanted to validate whether that is actually a viable option for some people, and you wanted to design an experiment, I think we briefly talked about that in Prague, maybe. How would you go about this? How would you design a trial or something that would test that on a viable level, on a reliable level?
it would be hard, but you could do some sort of longitudinal observational study, maybe where you might follow a cohort of people. Maybe, for instance, if you go to a festival, if you go to Boom, or if you go to one of these big, events where there's a lot of people using, um, whatever it is, you may try to sample from those people. Like, hey, are you here and are you using a psychedelic? Would you participate in research? You can, get a snapshot of their mental health history, and how they're doing at the time of the festival, and then you can follow people up. And hopefully what you will find is that some of the people have engaged in some, sort of counseling or psychotherapy afterwards, and some have not. And then you can, on purpose, just sort of investigate whether you see any separation or difference in terms of their changes in their mental health. It's a little harder to do prospectively because you'd have to like assign people randomly to groups, and then they would have to do what you want them to do. So that can, and the IRBs will get probably a little more prickly about some of the recommendations in this type of a situation. But I do think that with a longitudinal observational study, you could just look at people who did do that and who didn't do it. And you can look for any changes in terms of their mental health status. And that could at least, and that, is a type of work that CJ was trying to do. It was not a randomized controlled trial, but it was collecting data. And so we start to, answer a question, but we always end up with more questions.
And do you think for maybe people who are afraid of the experience, what do you think about this non-hallucinogenic psychedelic and that? Do you think that would work?
So we haven't been able to study these drugs very much for about 30 or 40 years. And so finally, we started looking at them again in 2000. And all of a sudden, in 2016, there was a small paper showing that psilocybin may induce neuroplasticity. And then in 2018, David Olson found that. And then since then, Alex Kwan has really shown some really cool shit with looking at, these are studies in animals, I should be clear. It's very hard to measure neuroplasticity in people because usually you have to cut the brain open and look at it, and we can't do that in people. But at least in animals, there's very convincing data now that you give a mouse one dose of psilocybin, and 65 days later, in their prefrontal cortex, we see a whole lot of new connections in between those neurons. And so the fact that these drugs do that, and that may be a primary mechanism of how they exert long-acting effects, is super interesting. And I think we should absolutely capitalize on that from a pharmacological standpoint. And so we can make new medicines that do that don't have a trip component involved, then those might be really useful for people with a dementia, for people with a schizophrenia or another psychotic illness, folks who may not be well suited to having these types of experiences. But I don't ever think that's going to take the place of the type of psychedelics that have been around historically that we've known for so long, and that even long historically been used specifically for the psychoactive experience, because for many people it seems as though the psychoactive experience is a central part of the treatment effect. And I wrote this in a paper like in 2021. It's like not a very famous paper, but at the end of it, I just said, I think that we can use these drugs, that they don't need to have psychedelic effects for certain conditions. And that includes things like migraines, which, for headache disorders and other types of cluster headaches, we can use them, and it doesn't need a trip. But my thoughts are that if you're treating trauma, if you're treating like deep-seated depression, if you're treating certainly substance use disorders, that in those cases, my experience has been that the big subjective effects that people have are a part of what they need to make a move or to make a change. So that's at least my thoughts right now. So I don't know that those new non-psychoactive psychedelics will work for everyone or will work as well. But they could be a new tool that could be quite useful.
And I
Thank
suppose we
you.
still don't really know if they are psychoactive,
We don't
really in
know.
humans. We are yet to find out. Thank you, Albert.
Yeah, I mean, we know that, and we know that from animals. We don't even know it from people yet. So it could be that some of these non-psychoactive psychedelics are quite psychoactive if we take them. So we got to try that and see. So
Okay, thank you very much. A request to all of you. For now, one question, no follow-ups, because we are slowly running out of time. Next question will be asked by Dorota, please.
Hello. And my question is, if tomorrow, if psychedelic became fully legal of therapeutic use, what would be your biggest hope and what would be your biggest concern?
So actually, those two things are quite related because my biggest concern is that there's not enough people really trained to do this type of work, and that there's a lot of people who have read about them and are very interested. And so a lot of people are probably going to go seek this out, but the infrastructure to do this safely will not necessarily be in place. And so my biggest hope is that we can scale up our training product, processes and programs so that there are different ways that people can access training. So, and I teach in like at least 3 different programs, for how to do psychedelic therapy. But part of the problem is it's not really legal to do it in most places quite yet. And so it's a weird thing for us to even be teaching. But the reason that I do it anyways is because we are kind of on a precipice where it may be the case that people will soon be needing access to this. And if you just have a bunch of not, untrained professionals out there, it could lead to problems. So those are, I guess, really like 2 sides of the coin there, is that I think this could be really good if there's the appropriate infrastructure in place. And it could lead to some harms. And a lot of, my other concern is pushback. If there are a wave of people who, have really bad outcomes, including things like suicide or other, bad reactions to these treatments, it could really quickly work against all of the science and research that have been happening for the last 20 years. So that is, something that I worry about. And the other thing, I guess, that kind of goes hand in hand with this is treatment access. And I think, especially in the US, we have a horrible for-profit healthcare system. And so if you don't have enough money, then you can't get the treatment. And so that worries me because as with most treatments, the only people who have a lot of resources will be able to get them. And then, that means a lot of people will be left out in the cold. And so I hope that we can get a lot of people trained, and we can also find better ways that we can improve accessibility so that anybody who wants to get this treatment can get it. And so I hope that, someday we'll have a clinic here, and that we'll be able to offer treatment for free for people who can't pay for it. And my dentist does that. She has a day every month where if you can't pay for treatment, then you can go to her and she will just, anybody that comes in that day, they're not paying. And so I think we can figure out models to do that. We just need to be creative. So, yeah.
Thank you. Next question, Eric, and then Justina.
Yeah, I wanted to ask about the psychiatric medications. So mostly the indication of psychedelics is like therapy resistant depression, anxiety, obsessive compulsive disorder. So there are data about SSRIs, SNRIs, NDRIs, and so on. But the psychotic disorders, as a psychiatrist, I wouldn't recommend to my patients to try psychedelics with psychosis, but our patients and clients are very, very creative. And the strangest thing I've ever heard was during aripiprazole therapy, which is a D2 antagonist and partially also serotonergic, they took psychedelics, psilocybin, LSD, ayahuasca, and it's still functioning. So it has less effect, it's less intensive, they didn't get psychotic, and they still get the effect. As it's legalized in Colorado and Oregon, is there any more data about antipsychotics and psychedelics? Because it's almost nothing you can find about it.
So far, we have very limited information. Probably, and part of the problem is we have data from old studies from the 60s, but, what they called psychosis and schizophrenia then, their kind of diagnostic criteria are quite different than today. And I'm sure, as you know, Eric, that they're even for someone with a psychotic disorder that can present in many different ways with positive symptoms and negative symptoms and schizoaffective disorders and so on. And so I suspect that, and even if you look at some of the early work with LSD, there seem to be certain pockets of patients there that were getting benefit and others who weren't getting much anything, good or bad, and others who were getting probably not very good effects. And so, our blanket kind of cautionary approach has been well, we're just going to lump all these patients together, including people bipolar too, by the way, not just psychosis, and say we're not going to give any of them these medicines because it could be a problem. And that's good for safety, but I think as we move the needle more towards accepting of these as new medicines in psychiatry, then people, and I already have colleagues and other friends in this field who are hoping to do early research studying MDMA or other types of psychedelics in patients with psychotic conditions. And so I think in the next 5 years we'll know more. And with places like Australia or Oregon or Colorado, or even now the Czech Republic, where we just met, that there's probably going to be new data available about, can these drugs work, and how, what can they be used for in those populations, and is there a safety profile there? But even, what you said about your patient and the aripiprazole is really interesting, because we don't really have that much information about how those drugs interact, So yeah. And please say hi to Maria for me. So
Yeah, Maria says also hi. Thank you.
yeah.
Okay, thank you, Justina, followed by Jagoda.
Hi, Albert. Thank you for sharing your knowledge with us. My question is quite related because it's often said that people who are at risk at developing psychosis can develop psychedelic-induced psychosis, and who is not at risk won't. And I wonder whether you consider the statement to be well supported by science and grounded in research, and what's your experience in that area? Because what I'm worrying about, obviously, is that the lack of data doesn't indicate that it doesn't support.
No, and it's just, it's such a complicated question, and we don't understand the genetic basis of psychosis anyways, and we don't understand fully the way that these drugs work either. And so there is so much that we need to be careful with, because obviously, in this sort of first do no harm situation, that tends to be like the number one. I'm going to see if I can drop this in here. Yeah. Okay. So this is probably one of the most interesting papers published recently in the area. Now, this is epidemiological data, so this is not interventional. But it seems to suggest that though there's some association between psychedelics and psychosis, that it's not clear cut. It's not necessarily that people who use these more are more likely to get this, a psychotic reaction. And as probably many of you know, there's also possibility that people will develop psychosis after many drugs, cannabis, various types of stimulants. And so this is something that it could happen. We just don't know, what exactly directionality is. Again, I kind of fall back on the data that we have, which is like the papers that I'm putting in here. But I would say we've been as careful as we can because we don't want to harm anybody. And so I think by doing very careful research, we may soon be able to find certain patient populations that could get benefits from this. But I can also say now that we've, having administered psilocybin to several hundred people at our lab, what we're doing is working. So we're not seeing a lot of people leaving the lab and developing psychosis. So by screening out people that have a history, personal or family, we seem to be at least blocking some of the risk there. The incidence of that happening in the early days of the research was quite low, but you have to think of the relative risk, and the prevalence of these illnesses is relatively low. I think it's in the order of about 1% of the population. And so, that's why it's hard for us to say anything, I think, with certainty until we get some more really careful, well-designed research. But there are some really interesting studies that have been published lately. These two, I think, on top are really cool epidemiological studies. And then I kind of, as a cautionary note, I did put a case series in there with a bunch of patients who developed psychosis after they took psilocybin, some of whom I think did not have a prior history, if I remember correctly. So, it's worth considering. And I think, if nothing else, that when let's say we are in a position where we're going to be administering these to patients or to research volunteers, then we always have to, at least for the informed consent, be very honest about the risks and about the fact that there are unknown risks. Psychosis, could be one of them. But I haven't seen that develop with many people, with anyone that we've, worked with at the lab. And so, yeah, that's, I think, about the best I can say right now.
Thanks.
Thank you. Jagoda, please.
Yes, hello, Albert, and thank you so much for the very interesting talk. I have a pretty general question. So we've mentioned many things right now, like HPPD and psychosis and the translation of animal models into treatment for patients. My question to you would be, for you personally, where do you think are still the biggest gaps in the research? Since we have a lot of data on certain aspects, but yeah, what are the missing puzzles still, and where would you like to see more studies?
I'm not really a scientist, I should say. So, I mean, I don't mind. I'm doing the research, and I think it's okay to do that. And it's been an avenue for me to be able to do the work. I would say that it's more interesting to me, which is the clinical work. And so I really like working with patients, and when we see them get better, then that's very rewarding, obviously. And when we work with psychedelics, I would say the rate of improvement tends to be better and more accelerated than if we're just doing talk therapy alone. So basically, having an opportunity to work with this kind of a tool and show in some way that it's safe and effective has been most of what I've been trying to do with my work. And everything else has just been kind of happening as extra, bonus. But of course, there's a lot of curiosity around the mechanisms. I don't really care that much about the mechanisms as a pragmatist. I think if it works, then that's good enough for me. But a lot of people want to know, can you do these, can you make these non-hallucinogenic drugs? I think maybe they could. I don't know that they're going to have the same type of impact. But I think that's one big question. What is the relationship of the experience to the therapeutic outcome? I think is really interesting. And we're still trying to investigate that, I think, pretty closely. One of the really most interesting things that I've gotten more and more involved with recently in the last couple of years, and actually this was what I was talking about in Prague, was about using this in patients that don't necessarily have psychiatric illnesses. And so the more we understand the biology of these drugs, I would say that has become a much more compelling question for me. And so that means understanding the biology of these at the epigenetic level, at the level of the immune system. So because we're seeing like these autoimmune related responses that are impacted by psychedelics, and how in the world does that work? And so that starts to get at things that are like what you might think of as a sort of mind-body problem, like, when you are not feeling well physically, how that impacts your mental health and vice versa. And maybe these things are much more interrelated than we thought. And a really cool new paper that was just published specifically speaks to that. And we're doing work now with, and I'll put the paper in the box here. This is with animals, of course, but it's showing that there's both these behavioral impacts of psychedelics, but also these immune impacts, and that they're related to one another. And so this is finally getting into like some really interesting questions about the biology of the drugs, like I said, and their impact on these various levels. I didn't even mention, but like the microbiome too, which we're starting to study now. But we don't really know what all of that's doing, all these bacteria that live inside of us. And of course, all of this and the brain mechanisms, what's happening in the brain with these drugs, I think that will give us plenty to study for at least, the next couple of decades. And so the more time we spend studying these things, the better not only we'll understand psychedelics, but I hope that we'll understand our own sort of biology and mental health and how they interrelate, and also maybe that will give us better tools to make treatments that work, that are more effective. So I think all of those things are pretty interesting and exciting. And I think of them as sort of new frontiers, like the effects of psychedelics in the body. And so when I was in Prague, I was talking about a study in patients with Lyme disease that we did where they had a really good benefits in their sleep and their, all these different in their pain. And now we're seeing studies in patients with chronic pain, patients with fibromyalgia, patients with Parkinson's disease, where they're showing benefits of psychedelics. And so we're rethinking that maybe this isn't all in your mind. And to me, that's pretty cool. So I guess that's an area that I'm very fascinated by right now at the moment.
Thank you. So, are we having time for some more questions, or you gotta go?
I mean, I have a meeting at 2 o'clock local time, so in about 15 minutes. But yeah, if there are other questions, I'm happy to answer.
Are there any audience? Last chance.
Hi. Hello.
Hello.
Hi, Albert. I just wanted to share with you my experience from Prague when you were here and you had
Oh,
your
nice.
talk.
Mhm.
When you were talking about how psilocybin can help with chronic symptoms of Lyme disease, I realized that I might have it, and I did, and I got it treated. And thank you very much.
Oh, that's fantastic. Yeah, well, I'm not sorry, I'm sorry that you're sick, but I'm glad that you could go get treatment. And
Yeah.
that is one of the diagnoses that's very difficult to make. And especially it may not be as prevalent now in Europe, but it still is actually the most prevalent vector-borne illness in the US and Europe. And with climate change now, that where all these ticks are located is kind of spreading. And so the likelihood of people getting a tick bite, these ticks have these bacteria, the bacteria get into the human bloodstream, and then they can cause these ongoing problems. But not all the doctors know to look for that. So I'm glad you went to go get it checked out. And I'm guessing they gave you some antibiotics and hopefully you felt better.
Yeah, it was first stage, and I remembered the tick during your talk, and I was like, oh my God. So thank you very much. It was right on time.
Well, I mean, that's just lucky, but I'm glad that they caught that and good. So, but very interesting, there are these people, we'll publish this in the fall probably, but we did a small study with patients with chronic Lyme disease. Lyme is a weird illness that we don't understand very well, but a lot of these patients keep having problems for a long time after their initial infection, and that includes pain and fatigue and difficulty concentrating. And when it's not treated, because some people won't even think to go, get checked out, then it can cause these lasting problems. And so we treated 20 patients with psilocybin. Many of them had great improvements in their sleep and their mood and their pain. And so now we're trying to understand how that works, and we're going to do a larger study. But yes, I'm glad that was useful for you. So
That's a wonderful anecdote.
Thank you, Leah.
Apparently, yeah. Dorota raises her hand. So another question, please.
I'm not sure it's the best question for the end. I hope I don't open a huge subject, but I would love to ask you, how has your work with psychedelics influenced the way you think about consciousness or the human mind?
that's a great question. When I started studying all this stuff, I was pretty young. I was, I don't know, 17, 18 years old. I was reading a lot, but reading Nietzsche and Sartre, but also reading like ancient philosophy, and then also finally reading more contemporary philosophy of mind and consciousness, and including people like Jerry Fodor, and then later people, that do this type of consciousness research, and including now much more advanced stuff like Giulio Tononi, and they create all these models of consciousness. And And I guess I became much more disenchanted with studying and thinking about consciousness, at least from an academic perspective. It almost feels like you're trying to explain something that I don't know that we'll ever be able to explain. So I've felt very satisfied with sort of leaving that question alone, experiencing my own consciousness and also the consciousness of other people around me, just in our, in our interactions. And, in terms of, what the psychedelic work has sort of brought to me is just, it's really kind of ongoing, and this has been there since the beginning, curiosity about, just how the mind works. And so I don't know that we'll ever really understand consciousness per se, or not in a way that's satisfying. I might be able to give you some, pictures of a brain or some, mathematical types of equations to try to explain it, but the experience of it is always going to be elusive. But then, people's minds, are so fascinating endlessly, and so that has just been kind of like the ongoing adventure of the work that I feel like we're doing, is just, trying to dig into that better and to understand it, and, trying to reconcile all these various models, whether you're looking at, a sort of, ego psychology model, like a Freudian or analytic model, looking at depth psychology, or looking like something like psychosynthesis from Assagioli, all these various schools of thought about what the mind is. Obviously there's all these contemplative traditions like Hinduism, Buddhism, and them having all these types of, conceptions of what the mind and consciousness are. It just kind of gives me an appreciation for how rich people's experience can be, and how much we have to learn. But yeah, ultimately, I think trying to put them in any sort of order is very difficult. That any order that makes sense. So it's really complex question that I don't know that we'll have an answer to in our lifetimes, but it's something that's fun to think about, at least.
Thank you very much.
Mm-hmm.
So, any last question, or was that the last question?
I think it was a good last question. So
Yeah, definitely, it was a good one. Thank you so much. I think we really enjoyed this time, and hope to see you another time someday.
yeah.
Best of luck with your research. When can we expect something new from you?
This year we'll have at least two big papers. We have our one smoking paper is under review right now, so I hope it will be published in the next 2 or 3 months, and that will be a big deal because it's really, I think the results are very compelling. And then the other one that I was mentioning, the chronic Lyme paper, should be out in the fall. I hope. I need to finish that, but it's almost done, and so those things will be coming out soon, and we have more work in the pipeline. So we'll just, we'll keep on publishing. And yeah, I hope, to be back in Europe again next year. And so certainly I try to connect with you guys again, Alan, Eric, it's been great to see you both again. And also, thank you for organizing. This has been a really good opportunity, I think, to have a great conversation today. So.
Fantastic. So have a good rest of the day. I'm gonna stay here for a while if some other participants have questions or want to chat. But thanks to Albert Garcia-Romeu for visiting us today. Much gratitude for you.
Of course. And thanks, Alexander, again for organizing. So, all right, I'll see you guys later. Take it easy.